Contrast-enhanced harmonic endoscopic ultrasonography for differential diagnosis of pancreatic cysts. Introduction. Pancreatic cyst is a frequent finding on cross-sectional imaging. Mucinous cystic neoplasms, MCNs, and intraductal papillary mucinous neoplasms, IPMNs, have malignant potential. However, these lesions can be followed up without surgical resection when they are asymptomatic and present without high-risk features. Serous cystic neoplasms and non-neoplastic cysts are generally not considered at risk for malignant progression. Therefore, after identification of a cyst, diagnosis of the cyst type and categorization of the cyst as benign, pre-malignant, or malignant is critical for guiding subsequent management decisions. Endoscopic ultrasonography, EUS, is superior to other imaging methods in terms of spatial resolution and is widely used to evaluate pancreatic cysts. Contrast-enhanced harmonic EUS, CHEUS, is a new imaging modality that uses an ultrasonographic contrast agent to visualize blood flow in fine vessels and has been shown to be accurate for the differential diagnosis of solid pancreatic tumors. CHEUS may also aid in the diagnosis of pancreatic cysts by enabling assessment of the vascularity of structures such as cyst walls, septa, or mural nodules, and discrimination between contrast-enhancing mural nodules and non-enhancing mucus clots. In this study, Kamata et al. Evaluated fundamental B-mode EUS, FBEUS, and CHEUS in the diagnosis of mucinous versus non-mucinous and malignant versus non-malignant pancreatic cysts based on the evaluation of cyst mural nodules. Background and study aim. Comparison of fundamental B-mode endoscopic ultrasonography, FBEUS, and contrast-enhanced harmonic endoscopic ultrasonography, CHEUS, in the differential diagnosis of pancreatic cysts according to presence of mural nodules. Patients and methods. Between April 2007 and April 2012, FBEUS and CHEUS data were prospectively collected from 581 consecutive patients with pancreatic cysts and were retrospectively analyzed from 70 with subsequent cyst resection. Presence and height of mural nodules as detected on FBEUS and CHEUS were evaluated, and the accuracy of the methods for diagnosing mucinous versus non-mucinous and malignant versus benign cysts were compared. Results. On pathological examination, 48 cysts were mucinous and 22 were non-mucinous. 30 cysts were malignant, high-grade dysplasia or invasive carcinoma, and 40 were benign. If presence of a mural nodule was considered to indicate a mucinous cyst, FBEUS and CHEUS accuracies did not differ significantly. Respectively, sensitivity 85% versus 79%, specificity 46% versus 96%, accuracy 73% versus 84%. If presence of a mural nodule was considered to indicate malignancy, CHEUS was significantly more accurate than FBEUS. Respectively, sensitivity 97% versus 97%, specificity 75% versus 40%, accuracy 84% versus 64%. For diagnosing malignancy by evaluating mural nodule height, the area under the receiver operating characteristic, AUROC, was 0.84 and 0.93 for FBEUS and CHEUS, respectively. Presence of a mural nodule of height greater than or equal to 4 millimeters on CHEUS was a sign of malignancy. False positive fraction 0.2, true positive fraction 0.93, odds ratio 56.0. Conclusion. CHEUS is more accurate than FBEUS for diagnosing malignant pancreatic cysts.